Hey, how's it going? Today we're going to be doing another presentation. So I've got a pretty quick presentation for you. It's going to be over basic EKG interpretation. Now, this presentation is essentially just going to be the stuff that we covered in class, but in a little bit more organized format.
So just like last time, there's going to be a disclaimer. This presentation is for educational purposes only. It doesn't replace your required readings, your educational activities, or any other formal learning. It's only meant to supplement your education, just meant to help you. In this presentation, we're going to do a quick review of the anatomy of the heart. We're going to talk about the cardiac conduction system. We're going to talk about what normal sinus rhythm is. We're going to talk about bradycardias and tachycardias. We're going to talk about heart blocks, irregular rhythms, cardiac arrest rhythms, and ectopy. I have a few rules before we start. So, when learning EKG interpretation, you must have a strong understanding of the heart's conduction system. And the conduction system essentially is just the wiring of the heart. If you understand how the heart is wired, it's going to make EKG interpretation a lot simpler. Now, this is my philosophy on teaching EKG interpretation, and I have three master rules to know before you get started. Rule 1, EKG interpretation is hard. Rule 2, sometimes you're going to be wrong even when you think you're right. And Rule 3, if you disagree with Rule 2, see Rule 1. Guys, this is not easy. There's a reason why people don't look forward to cardiology. But don't worry, because you're going to have a strong understanding of the conduction system, because that is how I like to teach it. Okay? It's still hard, but we're going to get through it. And remember, as you learn, give yourself some grace, be patient with yourself. We're going to get through this, okay? So the heart is simply an organ that generates electricity, and it uses that electricity to contract and pump blood through the body. We can measure that electrical activity on a graph. That's what an EKG does. Now the heart has four chambers. It's got two atria and two ventricles. It's essentially got two sides, the right side and the left side. The right side of the heart pumps blood to the lungs, and the left side of the heart pumps blood to the body. Now let's talk about the conduction system. Remember that the conduction system is really just the wiring of the heart. Now within the heart, there are three notable types of cells. There are pacemaker cells. These are the cells that initiate the electrical impulses that eventually lead to contraction. There are conducting cells. These cells form the wiring of the conduction system. And this wiring is where the impulse will flow down. Lastly, there are myocardial cells. These cells are called myocytes. These are the contractile tissue of the heart. These are the muscle cells that contract when they receive the impulse from pacemaker cells. Now, an important thing to note when learning the conduction system is that any cell within the heart can emit an impulse. This is a term called automaticity that you may read about in your textbook. So even though the heart has a normal conduction system or a wiring system, sometimes another random cell within the heart can emit an impulse that causes a beat. Also, there are a couple terms for you to be familiar with. There's depolarization and contraction. So depolarization and contraction are essentially the same thing. When an impulse goes down the conduction system and it gets to those myocytes, those cells are bathed in electrolytes. And it is the interaction of electrolytes, mainly sodium and potassium, that lead to the cell to depolarize and contract. So contraction and depolarization are essentially the same thing. Depolarization is simply the electrical process or the interaction of those electrolytes, and contraction is the mechanical process or the actual pumping of those cardiac cells. So the first part of the conduction system, or the first part of the wiring of the heart, is the SA node. The SA node stands for the sinoatrial node, is simply a bundle of pacemaker cells that sit high in the right atrium. Now the SA node is the chief pacemaker of the heart, and rhythms that come from here are called sinus rhythms. So in a normal healthy heart, the impulse that leads to the contraction of the heart should come from the SA node. Now the SA node has a firing rate of 60 to 100 impulses per minute. This should sound familiar, as when you learn in your vital signs, a normal heart rate is 60 to 100 beats per minute. This is why, because the impulse that lead to the heart to beat come from the SA node. The SA node activity, the electrical activity of the SA node, is represented by a P wave on the EKG. As long as the SA node is working, we're going to have a good upright P wave. Now once the SA node conducts an impulse, the atria depolarize. So those muscle cells, or those myocytes within the atria, they will depolarize and contract as soon as that SA node conducts an impulse. So the P wave represents both SA node activity and atrial depolarization. Once that SA node conducts the impulse, those atria depolarize, and that impulse travels down the conduction highway, or down the wiring, to the AV node. The AV node, or atrioventricular node, is the next stop in the conduction system, and it is a bundle of pacemaker cells that sit at the AV junction between the atria and the ventricles. The AV node acts as the gatekeeper of the ventricles. It will receive that impulse from the SA node, and it'll hold on to a minute. During this time, the purpose is to give time for the ventricles to fill with blood. Remember, when the SA node emits that impulse, it causes the atria to depolarize and contract. When the atria contract, they squeeze blood down into the ventricles. And the ventricles want to make sure that they fully fill with blood before they contract. So that's why the AV node holds on to the impulse for just a little bit of time. So that hold time is represented by the PR interval on an EKG. The PR interval should be 0.12 to 0.2 seconds in duration. So this is a very exact process that should take that specific amount of time. And that is to ensure that the ventricles have adequate time to fill with blood. Now, another interesting thing about the AV node is that if the SA node quits doing its job, the AV node can back up and can act as a backup pacemaker. Now, the AV node can beat at an intrinsic rate of 40 to 60. So it's a little bit slower than the SA node. Additionally, if the AV node takes over for the SA node, we will see changes to the P waves. The next stop of the conduction system, or the wiring, is essentially the ventricles. There are three structures we'll talk about: the bundle of His, the bundle branches, and the Purkinje fibers. But just know that all of these structures can be summarized simply as the ventricles. So once the AV node has given time for the ventricles to fill, it will release that impulse further down the wiring of the heart to the bundle of His. The bundle of His will bifurcate into the left and right bundle branches. These bundle branches take that impulse to their respective ventricles. The left bundle branch takes the impulse to the left ventricle, and the right bundle branch takes the impulse to the right ventricle. The Purkinje fibers are simply widely distributed conducting cells that help distribute that impulse to the ventricular myocytes. Once that impulse gets to the ventricular myocytes, depolarization occurs and contraction of the ventricles occur. Ventricular depolarization is represented by the QRS complex on an EKG. Now, if the SA node and the AV node both stop working for some reason, the ventricles can also act as a backup pacemaker, and they can fire at an intrinsic rate of 20 to 40. So this is the slowest backup pacemaker. Additionally, one thing that is important to know when learning EKGs is that electrical conduction, or the wiring of the heart, is not as efficient below the AV node. So, if an impulse originates from below the AV node or from within the ventricles, the QRS will be wide. A normal QRS should be in duration of 0.04 to 0.12 seconds. An impulse, if it originates from the ventricles, because the wiring is not as efficient within the ventricles, it will lead to a wide QRS, or a QRS that is greater than 0.12 seconds. So here is a graphic representation of what the conduction system or the wiring of the heart looks like in a very simple graphic. So at the top we have our SA node. It fires at a rate of 60 to 100 beats per minute at a regular interval. It is the chief pacemaker of the heart. Once the impulse is sent out from the SA node, we have depolarization of the atria. We have a P wave on our EKG. That impulse is sent down to the AV node, where the AV node holds on to it for just a very short amount of time to give time for the ventricles to fully fill and for the atria to empty. That interval here is our PR interval. This area from here to here, while the AV node holds on to it, that amount of time represents the PR interval on our EKG. It should be 0.12 to 0.20 seconds. Now once those ventricles are filled with blood, the AV node will release that impulse down to the bundle of His, where the bundle of His will fork into the left and right bundle branch. That impulse will be carried down both branches. It will split, where it is distributed to those ventricular myocytes, which leads to depolarization and contraction of the ventricles. Now remember that the AV node can take over at a rate of 40 to 60 if the SA node quits working. Remember, if the AV node takes over, we'll see changes to the P waves. If the SA node and the AV node both stop working and the ventricles have to beat on their own, they can do so at a rate of 20 to 40. So they are the slowest pacemaker. Additionally, the wiring in the ventricles is not as efficient as the wiring in the atrium. So if we have an impulse that originates from within the ventricles, we will have a wide QRS complex. Here we will quickly go over some EKG waveforms. So first we have our P wave, which is this structure here on an EKG. The P wave represents atrial depolarization. So that SA node has sent that impulse. It is called the atrial myocytes beside the SA node to go ahead and depolarize. Now it sends that impulse down to the AV node, where the AV node holds on to it. And that period of time is the PR interval. So it's kind of from here to here. So that is the time the impulse takes to get from the SA node to the AV node and then be released to the ventricles from the start of the P wave to the start of the R wave. And that should be from 0.12 to 0.20 seconds. Next we have our QRS complex. So this represents ventricular repolarization. Correction. The QRS complex represents ventricular depolarization or ventricular contraction. Same thing. Now, the QRS is this structure here. It's the larger waveform that you'll see on an EKG. So it should take a certain amount of time for a QRS complex for the ventricles to depolarize. It should take 0.04 seconds to 0.12 seconds. If the QRS complex is less than 0.12 seconds, we consider that narrow. If a QRS complex is greater than 0.12 seconds, we consider that a wide QRS. All right. Next, we have a T wave, which is this structure here, this waveform here, that follows the QRS complex. So the T wave represents ventricular repolarization, which is essentially recharging. After a cell depolarizes, it must repolarize. This is when the electrolytes interact and they get ready to fire again. So repolarization can simply be thought of as recharging. Now the T wave represents ventricular repolarization, and the atria also repolarize. However, this waveform gets buried within the QRS, so we don't see a defined wave for atrial repolarization. Lastly, we have the QT interval. The QT interval represents one full ventricular cycle from the start of the QRS to the end of the T wave. So this would include ventricular depolarization and ventricular repolarization. So it is essentially from the start of the QRS to the end of the T wave. Now the exact time for the QT interval can vary from males to females and age. Generally, you want your QT interval to be less than 0.45 seconds. Here is an additional labeled graphic of an EKG waveform. You have your P wave, your QRS complex, your T wave, your PR interval, and your QT interval. Remember, your PR interval should be 0.12 to 0.20 seconds. Your QRS complex should be 0.04 to 0.12 seconds. If it's less than this or less, we consider it narrow. If it's greater than 0.12 seconds, we consider that wide. Lastly, you have your QT interval, which is from the start of the QRS to the end of the T wave. It represents one full ventricular cycle, or depolarization and repolarization, and generally it should be less than 0.45 seconds. The first EKG rhythm we have here is normal sinus rhythm. So in normal sinus rhythm, the impulse is coming from the SA node like it's supposed to. It's being released down through the normal pathways. It is regular, as a pacemaker should emit an impulse regularly. It is within a rate of 60 to 100, the normal firing rate of the SA node. It is regular. We have a good normal P wave. Our PR interval is at the proper duration, 0.12 to 0.20 seconds. Our QRS is narrow, or less than 0.12 seconds. So this is a normal sinus rhythm as it meets all the normal functions. If this rate was less than 60, we would consider this sinus bradycardia. If the rate was greater than 100, we would consider this sinus tachycardia. So this is a sinus rhythm because the impulse that leads to contraction started from the SA node. Next, we have a junctional rhythm. So in a junctional rhythm, the SA node is no longer the primary pacemaker, and the AV node is having to send the impulse that leads to ventricular contraction. So a few things tell us that this is a junctional rhythm. One, the rate falls within 40 to 60 So on this strip, this is a rate of 40. So that falls within the normal firing rate of the AV node. We also don't have any P waves. Remember that if the SA node is functioning normally, we should have P waves. And if the AV node has to take over, we will see changes to the P waves. This particular change is absent P waves. There's no P waves at all. So with a junctional rhythm, you may see absent P waves. You may see P waves late if this impulse takes a long time to get to the AV node. The AV node may go ahead and start and send that impulse, and we may see that P wave kind of behind the QRS complex. Additionally, we may see an inverted P wave. If that SA node sends an impulse down, but the AV node blocks it and sends it right back up, we may see an inverted P wave with a shortened PR interval. Okay, notice our QRS is narrow, and this is because that impulse originates from above the ventricles. Remember that the conduction system is much more efficient in the atrium, so that leads to a narrow QRS complex. If the impulse originated from the ventricles, that wiring is much less efficient, and we would have a wide QRS. But in this case, we have a junctional rhythm that has a rate of 40. We don't have any P waves because the SA node's not the primary pacemaker, and we have a narrow QRS because the impulse is coming from above the ventricles. Now there are a few rate rules for a junctional rhythm. If you have a rate of less than 40, it is considered junctional bradycardia. If you have a rate of 60 to 100, it's considered accelerated junctional rhythm. And then if you have a rate that is greater than 100, you have what is considered junctional tach. Next, we have an idioventricular rhythm. Now, this is a rhythm where the SA node and the AV node have stopped being the primary pacemakers, and the ventricular myocytes have to send out the impulse that leads to contraction. So these cells here are sending out the impulse out to the rest of the ventricular myocytes to contract. So we see a few things that indicate this on our strip. So we have a rate of 30. Remember that the firing rate of the ventricles is between 20 and 40. So we have a rate of 30 on our strip. We don't have any identifiable P waves because the SA node's not functioning. We have a wide QRS. Now remember that the wiring system or the conduction system is not efficient below the ventricles or within the ventricles. So we know that this rhythm comes from below the atria because in the atrium, the wiring is much more efficient and we'd have a narrow QRS if the impulse came from the atrium. Because this QRS is wide, we know that this impulse originated from the ventricles. Additionally, there are a few rate rules with idioventricular rhythm. If the rate is greater than 40 but less than 120, we call this an accelerated idioventricular rhythm. Accelerated idioventricular rhythm is a really common reperfusion rhythm. So if a patient has a STEMI, they have myocytes that are infarcted or ischemic, and they get a stent and blood flow is reestablished to those myocytes. A lot of times they will become the primary pacemakers for a short time. You will have an accelerated idioventricular rhythm, and then it will quickly go back to normal. Now, if an idioventricular rhythm has a rate greater than 120, we consider this ventricular tachycardia. Next, we have ventricular tachycardia. So, in ventricular tachycardia, obviously, the SA node and the AV node are not driving the impulses. There are cells in the ventricles, myocytes that are leading to contraction, and they're doing so very fast. The ventricles have become the dominant pacemaker, and they are doing so extremely fast. In this strip, we have a rate that's probably well over 200. We don't have any identifiable P waves because there are no impulses coming from the SA node, and the QRS is wide because it's coming from within the ventricles where the conduction system or the wiring is not as efficient. Additionally, we can see that all of these QRS complexes are the same shape. This is considered the same morphology. We call this monomorphic VTAC, as all of the shapes of the QRSs are the same. Now, polymorphic VTAC occurs when you have an impulse, when the ventricles of the primary pacemaker going way too fast, but you have differing morphologies or differing shapes of the QRS complexes. A very common type of polymorphic VTAC is called torsades or torsade de poids. Most people will refer to polymorphic VTAC as torsades, but this isn't technically accurate, as torsades is just one type of polymorphic VTAC, and additionally, you can only call a rhythm torsades if you have evidence of prolonged QT interval. Our next rhythm is supraventricular tachycardia, or SVT. So technically, any tachycardia that comes from above the ventricles is called SVT, hence the name supra, meaning above. So we know that essentially in any type of SVT, the impulse is going to come from the ventricles up. But in clinical practice, when you hear SVT, whether it's in ACLS or on calls or in the hospital, typically SVT is going to refer clinically to AV nodal reentry tachycardia, which is a specific type of SVT that most people are talking about when they talk about SVT. So generally what happens in AV nodal reentry tachycardia is you have an impulse that gets released in the atria, and it kind of goes back and forth, and it gets bebopped back and forth between the SA node, the AV node, and the ventricles. And what you do is you just kind of have a cycling of this. But unfortunately, the impulses are able to make it down to the ventricles, and they get captured and they cause depolarization. So you have that impulse that gets caught in this reentry cycle that leads to firing and depolarization and contraction of the ventricles, and it causes it to do so way too fast. So a few ways that you can tell that this is SVT on this strip here is you have a rapid rate. SVT is normally well over 150, commonly around 180 to 120. In SVT, you will have absent or abnormal P waves, and that's because these impulses are getting caught up in this reentry circuit. Additionally, we have a narrow QRS. Remember, the conduction system is much more efficient in the atria than it is in the ventricles. So because this QRS is narrow, we know that it's coming from above the ventricles, and thus we can determine if we have a rapid, narrow complex tachycardia with absent or abnormal P waves. We can call that SVT. Next, we're going to get into AV blocks. So AV blocks are conduction problems that prevent the impulse from the SA node from effectively getting down to the AV junction and to the ventricles. Blocks generally happen because of conduction damage along the conduction pathway. Essentially, you get a little fray in those wires. This can be because of different things like structural heart disease, just general aging, and ischemia or infarction. There are 4 main types of heart blocks to be aware of. There's a first degree block, a second degree type 1, a second degree type 2, and a third degree block. In a first degree heart block, the only main problem in a first degree block is that there is a prolonged PR interval. Remember that our PR interval should be from 0.12 to 0.20 seconds. In a first degree heart block, there has been some damage on this conduction pathway from the SA node to the AV node. So the impulse is still coming from the SA node because we have a clear identifiable P wave. It's just taking a long time to get to the AV node. So a first degree AV block has all the rules of a normal sinus rhythm. You just have a prolonged PR interval, or a PR interval greater than 0.20 seconds. Now this is common after a vasovagal incident, and it is usually benign. The next type of AV block we have is a second degree type 1. So one component of a second degree type 1 block is we have a lengthening PR interval. So if we look here on our strip and we map out our PR intervals, we can see that each time it gets significantly longer. So if we look at this last PR interval compared to this first PR interval, we can see that it is obviously lengthening as the rhythm goes down. And eventually what we will have is we will have a P wave that doesn't conduct the QRS complex. So essentially what's happening is this impulse is not getting through the AV node down to the ventricles. So we've got some type of damage in here that takes longer and longer for that P wave or that impulse from the SA node to get down to the AV node. So we have a lengthening PR interval, and then eventually we're going to have a P wave that doesn't conduct a QRS complex. Again, this is similar to a first degree block in that it's common after vasovagal incidents, and it is also usually asymptomatic. The next degree of heart block is a second degree type 2, and generally this is a more serious manifestation of heart block. It has some similarities to a type 1, as you will have a P wave that eventually doesn't conduct a QRS, but we don't have a lengthening PR interval in a second degree type 2. We have a set PR interval. So all of these PR intervals are the same, but eventually we have a P wave that doesn't get through the AV node down to the ventricles. We just have a naked P wave. So in a second degree type 2, we will have a set PR interval, and then we will eventually have a P wave that does not conduct a QRS. So we have a impulse that gets sent from the SA node, but the AV node blocks it, and it's not able to conduct an impulse. Now, second degree type 2 heart blocks generally are more severe, and they may end up requiring treatment with a ACLS. Now, the final type of heart block is the most severe and most serious. This is a third degree heart block, also called a complete heart block. So in a complete heart block, the ventricles and the atria are completely working independently. They're not working together. It is essentially like someone stabbing a knife between the atria and the ventricles. So the SA node is still sending impulses. We still have P waves. So if I mark on my strip, I'm going to mark where every P wave is, or where every P wave should be. And our P waves are going to mark out regularly, so we can see P wave, P wave, P wave. Now, some of these P waves, we don't see them, and that's because they're buried within the QRS complex. But they line up where they should be. So we have regular P waves, which you will have in a third degree heart block. Additionally, we have wide QRS complexes because the impulse isn't coming from the atria, they're coming from the ventricles. In a third degree heart block, because the atria and the ventricles aren't working together, you will essentially have an idioventricular rhythm that the ventricles are doing, and the atria are just sending out their P waves. But because the conduction system or the wiring is completely damaged between the two, they don't work together. So this is complete atrial and ventricular disassociation. We have regular P to P intervals, as you can see by the red lines, and we have regular R to R intervals, as you can see by the green lines. So our QRS complexes are regular at a rate of 30, with wide complex, consistent with an etioventricular rhythm. Now, an important thing to note with a third degree block is sometimes if the block or the damage to the wiring is high enough, you may have a junctional rhythm instead of an etioventricular rhythm. So you may have a third degree heart block with an underlying junctional rhythm. But don't worry, the rules are the same when you're looking at it. You're going to have P waves that are consistently have regular P to P intervals, but they're not going to work together with those QRS complexes. The QRS complexes are going to be doing their own thing, and they're going to be regular with each other. So in a third degree or a complete heart block, the atria and the ventricles aren't working together. All of your P waves are going to be regular and line up, and all of your QRSs are going to be regular and line up, but they're not going to be working together. The next rhythm is atrial fibrillation. So this is considered an irregular rhythm. So what's happened in AFib is the SA node is not the primary pacemaker anymore, so you can see that there's not any clearly identifiable P waves. Additionally, a rhythm that comes with an impulse from a pacemaker site should be regular. So if it was coming from the SA node or even the AV node, it would be regular. Okay, so even though there's no P wave, that doesn't mean it's coming from the AV node because it is not regular. Atrial fibrillation is completely irregular and random. So in atrial fibrillation, the atria are just kind of quivering. And what happens is you have random cells in the atria, random myocytes, that are all emitting impulses. And eventually some of them make it down through the AV node. But this happens randomly, and that's why we get such an irregular rhythm. If you draw lines between all of your R to R intervals, they're all going to be different lengths. Okay, you see how much of a difference there is in these R to R intervals. You're absent P waves because the SA node's not the dominant impulse, and the rhythm is irregular because it's not a junctional rhythm. The impulse is coming from random atrial myocytes, and the QRS is still narrow because it is originating from above the ventricles. It still gets to participate in that nice, effective wiring. There's also some rate rules. If the rate is less than 60, it's technically considered AFib SVR or AFib with slow ventricular response. And if the rate is greater than 100, we call this AFib RVR or AFib with rapid ventricular response. The next rhythm we have is called atrial flutter. So in atrial flutter, the atria are sending too many impulses down to the AV node. So typically this is going to be at least 300 impulses per minute. Now remember that the AV node is the gatekeeper to the ventricles. Its job is to send an appropriate amount of impulses down. So the atria has gone haywire and it's sending out way too many impulses down to the AV node, about 300 per minute. Now in atrial flutter, the AV node is able to block all but some of those, and what you have is a rhythm with a lot of P wave looking waves called flutter waves, and then eventually you will have a QRS complex. So in this particular situation, we've got 3 flutter waves to 1 QRS. So what this means is that the AV node is able to receive 3 impulses from the atria and then conduct 1 QRS. So we would call this atrial flutter with 3-to-1 conduction, because for every 3 flutter waves or P waves that get sent to the AV node, only 1 gets through the AV node down to the ventricles. Now notice the QRS complex is still narrow, and this is because the impulse comes from above the ventricles. Now it is considered an irregular rhythm because at any time the AV node may go to 2-to-1 conduction or 4-to-1 conduction or back to 3-to-1 conduction. It all depends on what the AV node is able to block. Now, because there is consistently about 300 impulses per minute coming from the atria, we can kind of approximately estimate the rates. So for example, this 3-to-1 conduction that we see on our strip here, a lot of times 3-to-1 a flutter is going to be at a rate of about 100. Okay, 4-to-1 flutter is going to be around 75. 1-to-1 flutter is going to be 300, because remember that atrium's throwing about 300 impulses per minute. At 1-to-1 conduction, that means every one of those impulses getting through the AV node down to the ventricles. This is going to be extremely fast. So atrial flutter a lot of times is called a sawtooth rhythm or a sawtooth pattern. That's because of all these flutter waves taking up the baseline of the EKG. And if you kind of blur your eyes, it looks like a saw, or the teeth of a saw. And it is considered an irregular rhythm because at any time the conduction pattern may change. It may go from 3-to-1 to 2-to-1 to 4-to-1. A lot of times it stays regular, but it can be irregular at any time. This next rhythm is asystole. So asystole is simply the absence of electrical activity. This can be because of a completely terminal heart rhythm, or it may be because your pads aren't connected. So if you see asystole, always double check your pads, but it is the complete absence of electrical activity. The next rhythm is ventricular fibrillation. So this is also a cardiac arrest rhythm. In ventricular fibrillation, your ventricles are just quivering. This is sporadic electrical activity. Hopefully you can defibrillate the heart, and that can kind of reestablish normal conduction, kind of fix that wiring. But VFib is completely irregular, sporadic electrical activity. The next rhythm is PEA. So pulseless electrical activity is it's any electrical activity that doesn't produce a palpable pulse. So this can present with any type of rhythm. This can present as AFib. It can present as a type of block. So this is any organized electrical activity. So VFib would not be a PEA. Ventricular tachycardia is not considered PEA, it's considered VTAC. But it's any organized electrical activity, so normal sinus rhythm, sinus tach, whatever, that just doesn't generate a pulse. Okay, you have electrical depolarization present, but you don't have contraction. So the electrical component of it is present, but you don't have that mechanical contraction present. This is why it's important to understand that there is a little bit of a difference between depolarization and contraction. Next, we're going to talk about ectopy. Remember from earlier that any myocyte in the heart can emit an impulse. A myocyte that discharges an impulse anywhere other than the normal conduction system is called an ectopic beat. This can occur in the atria, the AV node, or the ventricles, and it'll create a premature complex. Now, there may be a little pause or in the baseline. You may have a sinus pause before or after this impulse. And these ectopic beats, they can come in patterns. We recognize a few common patterns like couplets, bigeminy, and trigeminy. So for example here, the first type of ectopy that we're going to talk about is called a PVC, or a premature ventricular complex. So if we look on our strip here, we have a normal sinus rhythm. So the underlying rhythm is normal sinus. Everything is working fine. It's coming from the SA node, good P wave, PR interval's fine, narrow QRX. And then we've got this kind of wham bam, large, wide complex, weird looking waveform here. So what happens in this PVC is you've got a normal underlying rhythm, but then for some reason, some random cell in the ventricles sends out an impulse that gets captured and leads to a QRS complex. So we know that this is a PVC, that it comes from the ventricles, because this QRS complex is wide. Remember, any impulse that comes from the ventricles is going to be wide because the conduction system isn't as efficient there. Okay, so this is a premature ventricular complex on top of a normal sinus rhythm. So we would call this normal sinus rhythm with a PVC. They can come from either ventricle, the right or the left. They're going to be wide complex. If you have more than one PVC and they are the same shape or same morphology, we call this monomorphic PVCs. If you have PVCs that are different morphology, we would call those polymorphic. Now, if you have two in a row, we would call this a PVC couplet. If you have three or more PVCs in a row, we would consider this a run of VTAC. Next, we have a premature junctional complex. So just like our PVC we just had, we have a normal sinus rhythm, and then we have this random beat here that's missing a P wave. So what's happened here is we've got a random myocyte in the AV node that decides they're going to send out the impulse. And we have a narrow QRS complex because remember it's coming from above the ventricles. The wiring of the heart is much more efficient above the ventricles, so we still have a narrow QRS, but we don't have a P wave. And that is very consistent with what happens in the AV node. So we in PJCs or premature junctional complexes are essentially single beats of junctional rhythms. And we will have either an absent, an inverted P wave with a short PR interval, or a late P wave. So here we have a single PJC. We have sinus rhythm with a PJC. And remember that PJCs will have a narrow QRS, and they will either have absent, late, or inverted P waves. Next, we have a PAC, or a premature atrial complex, or contraction. And what happens with a PAC is when a random myocyte out here in the atrium gets pissed off and it sends an impulse ahead of the SA node's impulse. So because this impulse isn't coming from the SA node, but it still causes the atria to contract, we have a QRS complex with an abnormal P wave. So if we look here on our strip, this P wave is certainly different than all of the other nice, crisp, and clean P waves. Also, the QRS is narrow, so this tells us that the impulse comes from above the ventricles. And additionally, we've got our abnormal P wave here. So if you have a narrow QRS complex that is led by a random abnormal P wave, this is suspect for PAC. Now you can have an entire rhythm of PACs. This is called an ectopic atrial rhythm. Additionally, if this rhythm is tachycardic, we call this multifocal atrial tachycardia, or MAT, because the impulse is coming from multiple foci, or multiple cells within the atria. So in this particular pattern, we have a normal sinus rhythm with a PAC, and that is evident because we have an abnormal P wave and a narrow QRS complex. We know that this is not a PJC, because remember PJCs have narrow QRSs too, but they either shouldn't have a P wave, should have an inverted P wave with a shortened PR interval, or will have a late P wave. In a PAC, we have an obvious P wave, it just looks abnormal. So here's an example of what a PVC couplet would look like. And remember that this can happen with PJCs. You can have a PJC couplet, you can have a PAC couplet. And then down below it, we have an example of a trigeminy PVC. So we have an underlying sinus rhythm with PVCs every third beat. This is considered trigeminy. If they were every other beat, we would consider this bigeminy. So when you're studying your rhythms, typically rhythm interpretation is done on a 4-lead and usually in lead 2. Okay, you can also use pads, but usually lead 2 is where you're going to get your strips. So now that you understand the conduction system, I want you to use the four steps below to figure out what's going on with each of strips. Okay, so first you're going to ask what is the rate. You're going to ask what is the rhythm. This means is it regular? Are there P waves? Are those P waves consistent? And is there one for each QRS? Is the PR interval normal? And is the QRS wide or narrow? So use these 5 steps, not 4 steps. You're going to find the rate. Is that rhythm regular? Are there P waves? Are the P waves normal? Is the PR interval normal? and then is the QRS wide or normal? All right, so here's our first set of practice strips. Pause the video here, and you can go ahead and knock out the interpretation. And I am going to go ahead and start working on how I would crunch through these. So I'm going to start up here with strip 1. So I'm start with my rate. So this strip is obviously rapid. The rate is probably around 180-ish. It is regular. I don't see identifiable P waves, so I can't assess my PR interval, and then my QRS is narrow. So I have a rapid, narrow QRS rhythm. I know it's coming from above the ventricles because the QRS is narrow, and I don't have P waves. So this is looking like SVT, so I would consider this SVT. Next, we're going to look at rhythm 2 right here. So my rate is very slow. I only have 3 QRS complexes, so that rate is approximately 30. It appears to be irregular. So when I have an irregular rhythm, it's probably one of 3 things. It's probably either a block, a rhythm with ectopy, or atrial fib. Now I have clear P waves here, so but it looks like I have a P wave that's naked. Actually, it looks like I have a couple P waves that are naked. Okay, so when I have P waves with no QRSs, this makes me think blocks. Okay, so rate is slow, rhythm is irregular. I have P waves, but not all of them have QRS complexes. So I'm going to look at my PR interval. So I see here my PR interval in these two are regular. So I have a set PR interval, and then I eventually lose a P wave. So that makes me suspect for a second degree type 2 heart block. Additionally, my QRS is wide, so that lets me know that the impulse is taking a while getting across those ventricles. So this rhythm here is a second degree type 2 heart block because we have a set PR interval and we have non-conducted P waves, or P waves that don't conduct a QRS. Let's see, now we're going to work on this third strip here. So rate, it is also slow. I see 3 QRS complexes, so we'll call this a rate of 30. Is rhythm, so kind of seems, okay, so it seems like the QRSs are regular. And I'm going to look at my P waves. So I do have P waves, but they're not really lining up with the QRSs. I'm going to go ahead and mark them. I'm going to go ahead and map them out. And I'm seeing a pattern here. So it looks like my P waves, my P to P intervals are normal, and my QRS intervals are normal, but they're not lining up. It's like they're not working together. They seem to, my atria and my ventricles seem to be disassociated. I also have a wide QRS complex, which suggests that the impulse is coming from the ventricles, so I probably have a third degree heart block. This is probably a third degree heart block. All right, here's the next set of practice strips. Pause the video, try your best, and I am going to start moving a little bit faster at my interpretation. All right, so over here in strip 1, we've got a rapid, wide complex tachycardia with no identifiable P waves. The wide QRS complex suggests that this originates from the ventricles, so that we'll call this strip VTAC. Next, in strip 2, so I've got a rapid, narrow complex rhythm. It appears to be irregular. It appears to be completely irregular. So because the QRS is narrow, I know it originates from above the ventricles. It is completely irregular, and I don't have any clearly defined P waves. So this is suspect for atrial fib with rapid ventricular response, or AFib RVR. Notice how coarse this baseline is. So interesting thing about AFib is the newer onset the AFib, the more coarse the baseline will be. See how it's all like blah blah blah, kind of a lot of artifact looking. But then the longer term AFib, the longer somebody has AFib, the more soothed out that baseline will be. before you get the irregular complexes. And then lastly down here, looking at the third EKG, we have a slow, so we have a bradycardia, so a rate of around 40. It appears to be regular, and I don't have any identifiable P waves, and I have a narrow QRS. So narrow QRS, I know it's coming from above the ventricles, it's come from somewhere AV node or higher, and I have absent P waves, so that is suspect for a junctional rhythm, and the rate is 40, so I know that falls in the normal rate of the AV node. So this is a junctional rhythm, or a junctional escape rhythm is also another word for it. Okay. This is the third set of practice strips. Feel free to pause the video and try to interpret them. All right, and now I will do my interpretation. So I have this first strip here. So I am looking rate, it is around 50. The rhythm, it is irregular. We should have a QRS complex here. Looking at my P waves, I already see a naked P wave right here. The PR interval, it appears to be, this is a tricky one. It almost looks like the PR interval is the same. I recommend always look at the first and the last PR interval. So if I compare these two, this PR interval is obviously longer before I get to this naked P wave. So I have a lengthening PR interval with a dropped P wave with no QRS. So this is a second degree type 1 heart block. All right, over here on strip 2, we've got completely sporadic heart activity. This is VFib. No need to look any further. This is VFib. All right, and then the third strip here. This is, it's obviously very slow. It appears we have a wide QRS. It's a little hard to see, but this is a wide QRS. So I don't have any identifiable P waves. It is regular. It's a rate of 30. So with those QRS complexes being wide, that suggests that it's coming from within the ventricles. And additionally, it falls within the rate of the ventricles. So 20 to 40 is the rate of the ventricles if they're the pacemaker. So here I have an etioventricular rhythm. All right, and this is the last set of practice strips. So feel free to pause the video here. And I will go ahead and begin my interpretation. So looking over here at our first rhythm. So we have a rate of approximately maybe around 80 or 70 or 80, so the rate looks fine. It is regular. Looking at my P waves, we have P waves, we have one for each QRS, but I noticed that this PR interval looks wide, okay? And I have QRSs that are narrow, so that suggests that the impulse is coming from above the ventricles, and I have a prolonged PR interval. So this is going to be a first degree heart block with that prolonged PR interval. Looking over here at the second EKG. So this is rapid. This is a tachycardia. It's well over 150. It's almost close to probably around 200. I don't have clearly identifiable P waves. I have a narrow QRS, which suggests that the impulse is coming from above the ventricles, somewhere in the atria. And this is a suspect for SVT. We have a rapid narrow complex tachycardia. This is a suspect for SVT. I would call this SVT. And then lastly, looking down here at lead 3, or excuse me, the third strip, we've got a changing morphology, wide complex tachycardia. So we know this is coming from the ventricles because these complexes are wide. These are all wide complexes here. And it changes its polarity. So this is suspect for polymorphic VTAC as it's changing its shape. So number 3 is polymorphic VTAC. We can only call it torsades if we have another EKG with a prolonged QT interval. So here are a few of the references. You'll notice a lot of Life in the Fast Lane EKGs. Life in the Fast Lane has a great selection of EKGs if you want to see some examples of different types. And these are the last of my references. Feel free to check out any of these. If you have any questions about this presentation, please feel free to email, text me, or message me, or leave a comment. This is very rapid fire, but it was meant to help you get the basics. Really work on understanding the cardiac conduction system, how the heart is wired, and that's going to help you a lot with your EKG interpretation. Thank you.